be able to hear everybody. They have to unmute it, but some of them are in.
Well, right now, I don't see anybody mic'd up for sound.
Okay.
Dr. Lake, it looks like you're the only one with the sound connected to you, so I think you're the only one we should be able to hear. Everybody else, I don't see a mic hooked up to the connection.
Okay. Let's begin.
Yes, that is one of the answering questions. Okay.
Okay. All right. Well, hey guys, thanks for joining us on this. I've got a lot of good cases here. I know I've met some of you and maybe not met others of you, but basically we'll just take you through a bunch of interesting cases, dermpath cases. And if anybody is at a moment they want to speak up, please feel free, ask questions. Don't be shy at all. This is pretty meant to be really interactive. So I'll start on the first case, and this was I think Rob's making an adjustment here. This was a case we received today, and it was a 55-year-old who had some kind of firm plaques on the lower legs, and were kind of indurated. So one of my colleagues did a punch biopsy on this patient, and at this power you can see that most of the inflammation is in the subcutaneous tissue. And let me just turn on the pointer to see if that works okay. There we go. And you can see that there's a lot of inflammation right here in primarily the lobules. So there's some fat degeneration, and as we go a little bit higher, there will be a nice focus here that I can point out that's pretty classic for this condition, and it's right centrally here. And this is a finding that maybe some of you might recognize called Lipo-membranous change. These kind of feathery projections kind of emanating from this cystic space. And when you see that, the diagnosis in the context of all that history is, and it goes by a few different names, but lipodermatosclerosis is the condition, otherwise called sclerosing panniculitis. And I think there's a few other names, hypodermatitis, sclerodermiformis, but I think lipomembranous panniculitis or sclerosing panniculitis or lipodermatosclerosis are the main names. So that's a pretty nice classic case of that.
If I may, I'm going to jump in, just let Dr. Patel know, if you guys want to type in questions, I notice nobody's mic'd up, please do.
Oh, wait. Okay.
So I'm setting up so Dr. Patel can see your questions down here. If you want to just type them in, that's fine.
What do I type
as
right
well?
here?
Yeah, you can type there, and that's their chat. Sorry, guys.
Okay, we'll go on to the second case here, and I'm going to go back to lower power. Hopefully the quality is okay for you guys. This is one of our first rounds of really doing this with a bigger group. I think we've got 17 in our group right now here. So on lower power, we just see a lot of sort of blue pockets of inflammation throughout the dermis. And at this power, we might be able to appreciate a little bit of sort of change around the epidermis as well. So then we'll go in on a higher power. Brighten this up a little here. And what we see here is we can tell that there's something going on along the junction here. You know, I even see at this power some basal vacuolization perhaps. And then we have this lymphocytic infiltrate that is superficial to deep, as well as perifollicular. And it just looks very blue, so there's a really good chance that most of this inflammation as we go on higher power really is just comprised of lymphocytes. We'll go on a little higher power, and we pretty much see that that's kind of the case. Let's go back up to the epidermis here, and we see this kind of basal vacuolization right along here. So we pretty much have an interface kind of process going. A little bit of epidermal atrophy, and then this lymphocytic inflammation that we saw in lower power, really perifollicular as well. And then this right here is really a plugged hair follicle. And if we caught this slide in another section, we might actually see this plugged follicle kind of perhaps opening up like right here. So follicular plugging is part of this whole picture, and the inflammation goes down pretty deep. And the quality's pretty good here. And then this is just predominantly lymphocytes, and there's also some plasma cells. I'm going to go on higher power just to kind of test this software to see how well we may or may not be able to see. So there are a few little plasma cells. Let's see if I can, there's a couple plasma cells right in here and here. Anyway, the findings in this thing are really classic for discoid lupus erythematosus. So this is a nice case of that. I'm going to go on to the next one here, and this is biopsy taken from an eyelid, and we'll go up on higher power because I think there's not much to appreciate at this level. And let me lighten that up. And even at this power, we can kind of start to appreciate that there are actually little aggregates of kind of cells, kind of inflammatory cells. Like here's another little aggregate here. I'll just kind of take us to higher power and look a little bit closer at what these look like on higher power. And we can see here that these cells are kind of enlarged. They're kind of pale, and even higher power, you see that kind of foamy cytoplasm. So eyelid skin, foamy histiocytes, and so the diagnosis on this is xanthelasma. Pretty classic. All right. We'll go on to the next one here. If anybody's having any issues with hearing me or any kind of problems, just feel free to type it. Oh, just one second. What features clue you in? Okay, I'm just looking at this. What features clue us in that it's on the eyelid? And let me kind of show you that. Eyelid skin, clinically and histologically is thin. So if you look at this epidermis right here, it's rather thin. I mean, you can kind of think about when we compare it to acral skin. So this is just very thin. The stroma, it's going to be a little bit tougher for me to sort of illustrate this to you, but the stroma in eyelid skin is just kind of a little bit loose, like right here. You see this kind of collagen isn't so densely packed like it is, for instance, in the back or something like that. So it's really just thin skin and loose kind of stroma. And that's kind of the main things that would kind of differentiate that. But you can't always definitely say, hey, this is from the eyelid, but those are some clues. This is just a little small shave biopsy that was done. And at this power, we'll try this out. If anybody has a clue what this might be, you want to either say it or just type it in. And I see somebody put BCC, and that would be something that would be something to pause for. Now, this one, I will say, is a little bit different from the typical BCC. And the first off, you'll see that these lobules here are reticulated and basaloid, but BCCs can do that as well, so that's not enough, but they're reticulated. The other thing that we're missing here that BCCs have is a good retraction artifact, and in fact quite the opposite. In BCC you get this fibro kind of mucinous stroma with retraction artifact, but here it's really kind of fibrotic. As we look in between these little blue islands, there's kind of fibroplasia. And then there's a kind of a third thing that just doesn't happen to be present in this case, but typically is, and usually we see horn cysts. So if you have this triad of reticulated basaloid lobules within a fibrotic stroma with horn cysts, it's a trichoepithelioma. So this is a good example, except it just doesn't have our horn cysts for a trichoepithelioma. Let me just make sure I'm seeing all your comments here. Okay, we're going to do another panniculitis here. And this one we just received last week. And incidentally, from the same doc that did the lipodermatosclerosis. She's seen a bunch of panniculitis for some reason recently. But anyway, the main pathology,
Dr. Patel?
a little lower power right here. As we scan on low power, you see the main pathology is down in the subcutaneous. Oh, do you usually see so much connection with the epidermis? I would say you can, but you know, not typically. It just depends on if you catch a hair follicle. You know, this is a follicular tumor, so hair follicles sort of connect with the epidermis, but I would probably say more often than not, I don't see that connection. All right, so subcutaneous tissue, and you can even tell that the septi here are rather thickened, and even over here they're very thick. And then there's a lot of inflammation here. I might need you to keep a little eye on the comments because I'm
Sure.
Yeah. And we'll go on a little higher power here, and we'll take a little closer look at this this inflammation. And you see that it's kind of marginating off to the edges of the subcutaneous tissue here of the lobules. So thickened septa. And we've got this kind of mixed inflammation that's primarily septal, spilling over a little bit into the lobules. And so this is a condition where you can get lymphocytes, histiocytes, multinucleated giant cells. You can even get some newts and eos, neutrophils and eosinophils in here sometimes. So anybody want to venture a diagnosis? That's correct. EN, I think somebody at UIC said. So yeah, this is a nice classic case of Erythema nodosum. So septal thickening and septal panniculitis with maybe some spillover into the lobules. All right. And by some coincidence, the same doctor 2 weeks ago had another panniculitis, and I'm going to show you that. We're on a panniculitis theme today. See if I have a good. Okay, slide's a little dirty. I'm sorry, but let me get to a better cut. So you can see at this power, not much in the dermis. A lot of what we're seeing is in the subcutaneous tissue here. And even at this power, we see just these purple deposits. Usually that's indicative of calcium. And so I'm going to go on a little higher power here. Focus for you. Okay, and then what I see really at this power, some inflammation. The lobules look kind of pale, so I suspect there's some necrosis in there. And then lots of calcification. This is all calcified material right in here. And then maybe some multinucleated cells reacting to the necrosis and the calcification. And then here we have rather, prominent kind of deposits of calcium. And then if we go into this little area, you'll see this kind of appearance of degenerated fat cells that are kind of calcified, these little areas right here. And we kind of have a sort of a textbook term for this. I wonder if anyone knows what that is, that sort of textbook term for this. That's exactly right. So these are ghost cells. And so anybody want to type in or say a diagnosis? That's perfect. That's right. Yep. Pancreatic panniculitis. So this is, one of those conditions that is basically classic. This kind of ghost cell appearance with calcification. There's really nothing else that looks like this. So this patient, when I saw this slide, I inquired with the doc, and has no known history of any pancreatic issues, but had some kind of recent issues of some, just GI complaints, bowel changes, nausea, vomiting, diarrhea. So I think some lab work is pending. I think they've got the amylase lipase, and they might be getting a CT, so they're trying to find out more. So I think this was a neat case. This is where we kind of came in to be able to offer the first clue that maybe there's a kind of a pancreatic issue with this patient. So, all right, we'll go away from panniculitis now. We'll do some maybe mix in some more routine stuff here and there. Anybody, even at this power, like to put a guess in? Warty D, that's correct. Is that Tirana? Okay. So yeah, this is a fairly well circumscribed and endophytic lesion with dyskeratosis and acantholysis, and so this is a warty dyskeratoma. If we were to take these changes and maybe make them a little more focal and really make them occur within the plane of the epidermis rather than down here, then we might call that Grover's disease. But this is a really nice case of a warty dyskeratoma. I go on to the next one. This is not the one. Let's see here. Okay. Okay, so we have a epithelial proliferation kind of coming from the epidermis and shooting down into the dermis. And as we go and we look at these cells, I think you guys, even at this power, might agree that they just look monotonous. Especially at this power, you see these cells just all look. I think it's looking pretty good on your screen there. It's a good resolution, but exactly, UIC said poroma. So this is a nice example of an Eccrine poroma, and these round, monotonous, uniform cells. And then this stroma is really classic. It's like basically I would call a fibro. This is kind of fibrotic, a little bit vascular. So fibrovascular kind of core to the stroma coming off of the epidermis here. So we call this Eccrine poroma. I think the other textbook, nomenclature would also call this a juxtaepidermal poroma. And then the comment was more like boroma. You are correct. That's a nice way. I've never heard that one actually before. But yeah, the cells are so similar. They're boring. I love it. So and then if we had these boring cells only restricted to the epidermis, then they would also be called hydroacanthoma simplex. If the cells break off and they're only in the dermis, then we'll call it a dermal duct tumor. So, all right, good. Thanks for that. I'm learning. And then let's see here. This might be a little repeat here. No, another case. Sorry, back to panniculitis. So at lower power, you see that the dermis, there's not much going on there, and the pathology is in the subcutaneous tissue. And look at this septal thickening here, actually pretty massive. So we'll just hone in on that. And you can see that there's inflammation and septal thickening. And I would say for the purposes of you guys in terms of board exams or testing, I mean, there's not much else that is going to be on your differential for panniculitis. It's going to give you this kind of septal thickening and septal panniculitis. And so this is Erythema nodosum. We can get a little higher power. And you do often get multinucleated giant cells, such as this right here. And get some of the inflammation sort of lining up on the edge of the lobules. So another erythema nodosum here. It's almost frankly granulomatous, small granulomas. Erythema nodosum. All right. Okay, another one. Anybody want to take a shot? Diagnosis? So you can see, somebody said scar. That's one thought. You see this kind of fibrotic areas here, maybe with a little vascular prominence. As we see, and morphea, yeah. So somebody else said morphea, and morphea is right. So even at this power, I think you can kind of appreciate that it's a really somewhat of a square biopsy. The other thing that there's just not that many appendages. We got a little bit of residual kind of muscle bundle here, but by and large, there's really no hair follicles in here. And then along with morphea, which is, sclerosus and fibrosis throughout the dermis, lack of appendages, also a superficial and deep kind of lymphoplasmacytic infiltrate. So this is really a nice classic case of morphea. Okay. All right, so a little tough to pick out of this power. We'll go a little higher power. So we have these little aggregates of inflammatory cells in this area, and then I would say another little aggregate kind of right here. You guys are all welcome to speak or type in whatever your thoughts might be, even as we're going through it. And then right here. And that's right, yep, UIC. Yeah, and this is really just a nice classic granuloma annulare. Small palisading granulomas. So you got these histiocytes around the edge, and then we've got a fair amount of mucin right in the middle of this one here. So, and even out here, you see the inflammation is kind of just getting a little bit more like interstitial. And here's a little pocket of GA kind of inflammation. And back to this area here, a little bit of mucin here, and then this palisade right here, another palisade here. So it's a nice classic case of granuloma annulare. Okay. This was one we received recently, and the patient had numerous kind of truncal, really just brand new hyperpigmented patches all over. And so this biopsy was performed, and you see the deposits of pigment in the upper dermis. These are all melanophages here, right here, here, here. Yep. And there's a fair number of melanophages, and I think the comment was EDP. So yeah, that is correct. Good job. This is Erythema dyschromicum perstans, or ashy dermatosis, and that's the clinical kind of put it together because the histologic features of post-inflammatory hyperpigmentation can look completely identical. Yeah, that's correct too. So you can sometimes get just a touch of interface kind of change with Erythema dyschromicum perstans, but by the time we get the biopsies, the rash is aged to some extent, and you get this picture. So good, that was great. And I think they did a second biopsy on that patient, similar and same, Erythema dyschromicum perstans. We'll go on to another recent case, and we'll go on a higher power. Patient has a 15-year history. This is a patient from our practice. A 15-year history of light patches of skin, and a dark-skinned person, but relatively light patches of skin. And I think somebody already put a good comment in, and that is perfect. Yeah, so you have appreciated these lymphocytes in the epidermis, and so this is in fact Mycosis fungoides. Let me get a little better picture of this. All these little blue cells right here are lymphocytes, and they're really rather prominent. Especially we go out here, you see a number of them, and so this really, and these little blue cells right here. So fair number of lymphocytes in the epidermis without a significant amount of spongiosis. If you had a lot of spongiosis with lymphocytes in the epidermis, then you're more into a spongiotic picture. But for all the lymphocytes that are in here, there's just not that much spongiosis. So yeah, this ultimately is Mycosis fungoides, and in the clinical context was a case of hypopigmented MF. This is just one kind of for interest I got recently as well. And this was taken from the lip of somebody who had kind of like a little papule on the lip. And if we go down to this piece right here, you kind of see that there's some kind of bluish material here. And I think Tarana said filler, and that's exactly right. So this happened to be a Juvederm injection. I don't know how long ago they had the injection. It was actually, I think, some time ago, and then somehow this papule kind of presented itself after the fact, later after the fact. So yeah, this is basically a Juvederm injection, hyaluronic acid. If we were to stain this with Alcian blue or other mucin stains, it would stain positive. So this was I've seen a few of these every now and then. So occasionally we'll see them with the granulomatous reaction, which is kind of a problem. So okay, good, Juvederm. Let's do one of these here. All right, I'll go a little quicker through this one. Feel free to put in your guess at this point. I would call it a guess. You guys know these things. Looks like the other one we saw just a little bit ago. So this is Morphia again, different case. So sclerosis throughout the dermis, nearly complete absence of appendages, and in the superficial and deep infiltrate. All right. All right, anyone just at this power here want to type in a diagnosis? Yep, that's right. Jackie said Lichen, sclerosus, atropicus, and this is really just a nice classic case. So we do sometimes get a little bit of a plugging here. We get the epidermal atrophy, and then in the upper portion, really the papillary dermis and a little beyond, you get this sclerotic band here, homogeneous. So you almost, it just almost looks like it's been painted on with a paintbrush. It's just so homogeneous and uniform, and just subjacent to that, you usually get this kind of band of lymphocytes. So, and then it kind of just stops. Right here you should have normal, basically we do have, for the most part, normal collagen here. Somewhere in the collection, I don't know if we'll see it today, but you can also have overlap of LSNA and Morphia. So you'll see this kind of pathology here with some lymphocytes here, and then it'll look like Morphia underneath, and that's been well reported. Diagnosis, anyone? Nothing else. That's correct. Yeah, scabies. A couple people mentioned scabies. Yeah, nothing else does this, so there's nothing to confuse this with. When you see these kind of little foreign sort of parasitic structures in the stratum corneum, that's pretty much what that is. And even for board examination, I don't know, not too much effort is really needed to distinguish all the little parts of the scabies mite. And you see something like this, you just know it's scabies, and you kind of move on to your next board question. All right. Oh, okay. I think we lost some audio, is that right? And can they hear me at all? No. Okay. Okay. Okay, yeah, we lost audio a little bit here, but it should be back. Oh, County and Rush are all frozen as well. Are you guys back up? Back. Okay, it's back now. Okay. Any diagnosis on this one? Yeah, that's right. UIC Lichen planus. So this is just a nice classic Lichen planus case. So hyperkeratosis, hypergranulosis. You got the sawtooth kind of acanthosis and a lichenoid infiltrate with these melanophages. So this is a nice classic Lichen planus. All right. So we have these big deposits of calcium just under the epidermis. And when we see calcium, we can kind of generically call this calcinosis cutis. This happened to be a youngster, and I think this was from the head and neck area, which is sort of a common situation for this condition. So it's calcinosis cutis, but it's a kind of a distinct entity that's got a special name. I'm not sure if anyone's familiar with this in that clinical context I just mentioned. So this is a entity that's known as a sub-epidermal calcified nodule. So that's the clever name they came up with. But if you look it up, that's just what it's referred to. Sub-epidermal calcified nodule, usually in kids, head and neck region, idiopathic, just a kind of a subtype of calcinosis cutis with no implications. All right, we have this is just kind of an epidermal invagination here with a little hyperplasia.
Yes.
And then I think somebody's already put in a comment, and that's correct, because you see that this is sort of degenerated collagen underneath here. You got a little vascular proliferation, and you get a little fragment of cartilage. It was a nice nice clue. So this is, just as you said, was a chondrodermatitis nodularis helosis. If you're not given this piece of cartilage in the sample, really should still be able to make the kind of diagnosis. You get this kind of collagen degeneration, and you, question here, I don't see any fibrin or granulation tissue. Yeah, it all can kind of vary, and really more than just frank granulation tissue. What I really often see is sort of a component of granulation, just the vascular proliferation, and it often does kind of line up around the sides and underneath here, like this right here. And then you'll see this kind of vascular proliferation right here. And this is really, I would say, almost like a really fibrin or collagen kind of degeneration more so. If you take this collagen right here and you kind of compare it to the normal collagen, you can see the difference. This is just more kind of, really more kind of fibrotic as well. So. And you will, as a subtle kind of thing, sometimes see these little scattered necrotic keratinocytes like you do right here. That's just the pressure effect of sort of laying on that repeatedly. I'll get some more slides here. Okay. So now we're into an inflammatory case here. Going a little higher power. Any general family you guys want to put this in terms of inflammatory? Spongiotic, yep, that's correct. So yeah, you see these little clear spaces between the cells. So this is spongiotic dermatitis. I would say that on top of that, you see these kind of parakeratotic areas here. And this is, yeah, that's correct, PR. Yeah, this is the mounding of parakeratosis. Here's a mound. Here's another mound. So you have multiple mounds of parakeratosis with spongiosis. And I would say in pityriasis rosea, which this is, the term I kind of use is muted spongiosis. So you don't often get really to having frank vesicles. It's just kind of a mild spongiosis that's sort of evenly distributed throughout much of the epidermis. So and then some inflammation in the dermis. Sometimes you get extravasated red. So, but this requires clinical context, so this could easily be atopic dermatitis or nummular dermatitis or id reaction, seborrheic dermatitis, a number of other conditions. But in the proper clinical context, this is a type of spongiotic dermatitis that actually is pityriasis rosea. All right. right, we have a pigmented lesion inside someone's mouth. And so you see this big obvious clump of foreign material right here. And I would say you don't actually normally in this condition always get such a nice obvious clump of foreign material, but more so you usually get what we see here, and I go on higher power, and really just these little dark foreign particles. And someone has listed amalgam tattoo, and that's exactly what this is. So it's a great case of an amalgam tattoo. Dark black particles. Hopefully you guys are seeing these images okay. I mean, from what we see here, it looks like it should be pretty good for you. That's amalgam tattoo. All right, somebody said they're great, so that makes me happy. Now here's an example I'll often show you. I probably have showed you guys this kind of different. Oh yeah. Oh yeah. Yep. Oh yeah. Lower power of the mouth. Yep. Oh yeah, that is mucosal. Yep. So it's not keratinized really. It's and you don't really have a kind of a granular layer. So it's non-keratinizing, no real granular layer, and then really that's the main thing. We're focused here. Very welcome. All right, amalgam tattoo. Okay. So at this power, you can appreciate that there's a little bit of hyperkeratosis, a little bit of acanthosis, and it's a little bit papillomatous. And the example I give, and it'll make more sense in a second, but it's almost like a roller coaster. You're kind of going up and down on this roller coaster ride right here. So it's this kind of subtle, I call it subtle, kind of undulating papillomatosis. And we'll go on a little higher power. So this comes with a differential diagnosis, and it really depends a lot on the clinical context. So, and all those comments you guys put in are perfect. So, you know, you guys said acanthosis nigricans. Absolutely. If this were on the you know, back of the neck of somebody and they have these velvety patches, that's what it is. Or if it's central chest or central back with these hyperpigmented velvety plaques, it would be confluent reticulated papillomatosis. Solitary lesions, say on a 12-year-old on the neck, then it's epidermal nevus, and that's what this kind of context was. So this is actually an epidermal nevus, you know, elderly person or older person with 50 of these on their back, then it's seborrheic keratosis. So this is epidermal nevus, and that's just a nice differential to remember. Let's see here. Yeah. Okay, so we've got this. Let me go on lower power for a second. Really just a nodular aggregate of this material here. And I think you can almost kind of appreciate, even at this power, and that's absolutely correct, somebody said mixed tumor, that it's chondroid. And so it's, you've got this sort of combination of, you know, these little lumen all over the place, and then the stroma varies, fibrotic, chondroid. In other areas it can be mucinous, and it's sort of well defined. So this kind of tumor can vary a lot, but yeah, this is a chondroid syringoma, also called mixed tumor of the skin. And again, it's called mixed tumor because all these components can vary a fair amount. Let me go on higher power just so you guys can see it. All these little ductal spaces, but really, you know, well demarcated, not encapsulated, but just well defined. What's that? No. All right, great. Chondroid syringoma. Okay. Anyone want to throw a guess out already, even at this low power?
Yes.
What's that? Hydrocystoma, that's right. So this see little apocrine lining in this one. A little dark. So this is a hydrocystoma. All right. So we've got this sort of large kind of cystic area, and you guys recognize these cells right in here called shadow cells, and that's right, there's a pilomatricoma. So typically you get, and I'm not sure if we have any good sort of basaloid islands in this, but typically you get these basaloid cells which kind of transition into cells that have these sort of dying pycnotic nuclei, and they follow up with these shadow cells. Real nice, perfect example of shadow cells here. Okay, I'll brighten that up a little. Also accompanied by some granulomatous inflammation right here that you often see because the body's sort of reacting to the shadow cells. Calcification are these purple areas, which you often get. So this is a nice pilomatricoma. Okay. All right. Let me darken this up a little. So really we've got this one lower power, this sort of endophytic proliferation, hyperplastic, and you can see already kind of get a sense that it's got some follicular differentiation right here. You can kind of just sense that here. And within it, we've got actually little squamous eddies. So these are all like perfect textbook squamous eddies, kind of all throughout here. Not a guess. And then somebody put in inverted follicular keratosis. That's exactly what this is. So it's got a lot in common with the entity known as an irritated seborrheic keratosis rather than an inflamed seborrheic keratosis. So with the endophytic, the difference being it's endophytic, more follicular differentiation, and you do get squamous eddies. So this is a real good example of an inverted follicular keratosis. Right. Grab a couple more cases here. Let's see. Lose cases. Okay. So I think what you all I'm sure notice is this at the top of the stratum corneum, this sort of foreign area of material, and all this purple stuff is usually just calcification, but at the rim, kind of at the edge, you'll notice this kind of eosinophilic periphery here, and when you see that kind of periphery, even with calcification, that's indicative of bone. And I'm afraid that, you know, the rest of it's kind of chunked off, so we don't really have the best specimen. But this right here is indicative of bone. It's calcified bone, and on top of that, it's perforating. So this was probably sitting down here before, but so this is just a quick example of a perforating osteoma cutis. All right, anyone know what this is? Oh, let me get that back in focus here. Yeah, that's right. This is the most regular acanthosis that you'll see. So you could draw a straight line under it. So this is a perfect kind of textbook case of psoriasis. But just to revisit it, you've got these little aggregates of neutrophils. You can even see right here a few neutrophils right here kind of percolating in the upper part of the dermis, and that's the spongiform pustules of Kagoi that are listed in textbooks. Psoriasiform acanthosis, a little bit of proliferation or dilatation of vessels in the dermal papillae, and then you got this lymphohistiocytic infiltrate here. So this is just a really nice classic case of psoriasis. I like to sort of sometimes take these conditions and turn them into other conditions. So if I were to sort of take psoriasis but want to turn it into, just as an educational exercise, turn it into pityriasis rubra pilaris, I would like to take the neutrophils away, because pityriasis rubra pilaris doesn't have neutrophils typically, and make it more, rather than uniform parakeratosis, I'd like to kind of alternate the hyperkeratosis and parakeratosis. Next thing I'd like to do is not make it so regular, because pityriasis rubra pilaris really is an irregular acanthosis, and rather than these thin psoriasiform features, they're more sort of bulbous, so it's kind of a broad-based sort of acanthosis that kind of goes down like that. And those would be some of the features if we wanted to take that exercise and turn it into PRP. And then this is taken from someone's axilla. Got a guess here. Yep, and that's correct. Yep, we had a couple responses, and several that are Hailey-Hailey. That's perfect. So this is all just sort of secondary necrosis. They must have done something to it, but really this classic areas are really right in here. So you have this full thickness acantholysis, which is often referred to as a dilapidated brick wall. And I think there is some dyskeratosis here, but I think it's just kind of secondary in this case, so I'd ignore that component. But you can see this acantholysis kind of spanning the thickness of the epidermis. Okay. Great. Hailey-Hailey. Let me see if this was a good one. I can't. No, I think we... Sorry. Skip that one. Sorry, I'm going to skip that one too. All right. This is submitted as a rule out BCC. I often get these in the lab. Rule out BCC, say on the cheek or the nose. And we just get this kind of inflammation that's perivascular, also a little bit perifollicular. Some telangiectasias right here. There's a few telangiectasias. So really just inflammation, telangiectasias, facial. And this is a good case of rosacea. If we really wanted a nice textbook, we might have a hair follicle with Demodex mites, but this is really what most rosaceas look like. Okay. All right, so we have a small focus of acantholysis. Anyone want to type in I know you guys know this one. Grover is perfect, yeah. So as opposed to the warty dyskeratoma we saw earlier, this is not so endophytic, and it's really a small focus of acantholysis. So, and you have another little focus of it right here. So this is Grover's disease. All right, we have this big chunk of someone's heel without epithelium available, and this big focus of hemorrhage. Yeah, talon noir, that's perfect. So yeah, hemorrhage in the stratum corneum. We don't happen to, maybe a little epithelium there, but this is talon noir. All right, we'll go to another inflammatory. Going a higher power. I think the lower power is a little tough to appreciate on that. Anybody want to type in or say category of type of inflammation? Yeah, there's dyskeratosis. That's exactly right. Whenever you see dyskeratosis, indicative of there may be an interface dermatitis. So that's what I was kind of getting at. So there's basal vacuolization really all along here. So we have basal vacuolization, all these necrotic keratinocytes, lymphocyte exocytosis, and then some lymphocytes down here. Maybe a little bit of good comments. Okay, good. All right, let me look at your comments here. Okay, yep. So interface dermatitis, and that's correct. All these things are on the differential. So erythema multiforme, acute graft versus host disease is on the differential. You can have some pretty sort of just routine drug eruptions that can have an interface, not usually to this kind of degree. And if we kept going, you know, we could add connective tissue disorders onto the differential diagnosis, such as systemic lupus erythematosus, dermatomyositis. So that's kind of the nice differential for interface dermatitis. This case happened to be systemic lupus erythematosus. I think I do recall that I don't think I was that impressed with, there might be a little bit of mucin in here, maybe a touch, see if I can, I don't know if you can appreciate a little bit of that mucin. There is a little bit kind of in this area right here. So anyway, this is not the best amount of mucin that we would see, but this is systemic lupus erythematosus. Okay. Give me just a minute. I'm going to grab some more slides here.
On a side note, just to let everybody know, this session is being recorded, full audio, of course all video. So once we figure out, you know, means of storing it, we'll make it available to anybody that may have missed the session, or if you want to, you know, review it at a later time.
All right, how we doing? Are you guys being able to see this stuff okay? Guys, hopefully the quality's still good. Okay. All right, so here we have a superficial and deep infiltrate. Let's go a little bit higher power and take a little closer look at the inflammation. Even at this power, you can kind of sense that it's pretty blue, so it's probably mostly lymphocytes, and that's the case. It looks like pretty much lymphocytes. I think the other thing that we do see in here that is, I would say, rather just much more obvious is right in here. There's actually a fair amount of mucin in this area. And let me just test this software and see if we go higher power if you can really appreciate it. Okay, yeah, it really kind of pops out pretty good. So so that's all mucin. It's that stringy, sort of pale bluish stuff. And so we have superficial and deep lymphocytic infiltrate, and in this case a fair amount of mucin. You guys have any? And really, epidermal-wise, not much in the way of any changes. So so I think by not having much epidermal change, we could take things like SLE or dermatomyositis or SCLE, subacute cutaneous lupus erythematosus. We can take those things kind of out of the differential. We can take discoid lupus out of the differential. So let me just come down to the bottom of the comments. So yeah, I lost track there, but yeah, that's right. People, a couple people said tumid lupus erythematosus. That's perfect. That's exactly what this is. So. All right, tumid lupus erythematosus. Next one. This might have been one that we recently did a case of the week on our website. We'll post usually every week or two cases on our website. Rob can give you the info on that if you want. But this one here was recently posted. And we have these aggregates of inflammation, and I think even at this power you can kind of appreciate that really it looks granulomatous, these sort of pale, round granulomas. And then a little bit of lymphocytic inflammation here, but not much. And here's a so-called naked kind of granuloma. And someone just mentioned the correct diagnosis, which is sarcoidosis. If you want to stretch the differential on these things, of course, infection, foreign body reactions, depending on the clinical context, granulomatous rosacea, but, this is pretty granulomatous. So, all right, cutaneous sarcoidosis. Here's one that, depending on who you ask, is a little bit of a subtle kind of diagnosis in this one here. But if you look at the normal kind of epidermis here, and you go over here, you see that it's a little hyperplastic over here, and it's more pale, especially as you get into here. It's kind of got this sort of pale look, and it's got these little sort of projections coming off. And over here, you see these little sort of projections kind of emanating off. So, and even here you can get an edge of one right there. So it's kind of pale projections coming off of the epidermis. Here's another, you can see this kind of hyperplastic pale area. So this one's a little subtle, but it's the pathology is there. So this is actually a tumor of the follicular infundibulum. I think when I do these, I don't think the residents often have too much of a chance to see this particular one, but just another one of these follicular tumors. The name tells you it's derived from the infundibulum, which is a paler portion of the hair follicle, so this is TFI. Okay. So we are in another category of, what would you categorize this as? Sub-epidermal. And there is some spongiosis. Yeah, we got some eosinophil, but even more so, it's subepidermal cleft formation. So, yeah, bolus. Yep. So, lots of eosinophils. All these cells, like, really packed in right here. These are just tons of eosinophils just filling up the area. So, yeah, subepidermal cleft with a bunch of eosinophil, that's bolus pemphigoid. Or pemphigoid gestationis. If you didn't have the blister, and let's just say, for example, you only had this kind of focus right here, no blister, bunch of eosinophils, almost in a kind of a band distribution under the dermis, then you have to think of the urticarial phase of bolus pemphigoid. Fortunately, in this one, we got the blister. Okay, this is really pale because of the tissue. Bear with me on the lighting because just the condition here is tough to illuminate. But I think you'll notice a lot of changes in the dermis here, kind of throughout the whole dermis. It's just not much happening in there. There's really no appendages. Sclerotic. And as someone mentioned, radiation dermatitis, which this is. So this is chronic radiation dermatitis. And the main features, as opposed to the lichen sclerosus atropicus that we saw earlier, where the sclerotic area was pretty much limited to this area, and then there are some lymphocytes underneath, well, you see that the sclerosis extends all the way down here. So it just isn't part of LSNA. You also will get some telangiectasias, which you can also get in LSNA. And then there's a kind of a variability. So the radiation, hits the area and it causes kind of these variable areas where it's more sclerotic in some areas. You have a little bit of solar elastosis that's being preserved and didn't become sclerotic. You got a little fat herniation through here. But the main thing really, no appendages, pan-dermal sclerosis. So this is chronic radiation dermatitis. Okay. That one right there. And that was good. Yeah, you got this melanocytic proliferation, starts and stops here, and starts and stops there. So it's really small, well-defined, epithelioid to spindle-shaped cells, and also, yeah, we really got a good example of caminobodies right here. So there's actually really numerous caminobodies in this. These are large caminobodies right here. So yeah, you guys of course are correct. This is a Spitz nevus. This was a youngster. When I see these in adults anymore, I'm usually excising them. Spitz nevi in adults are sometimes difficult to predict their behavior. This one's a little tricky. I think the pathology here might take you to potentially two different diagnoses. When you see this sort of kind of really almost suprabasal suprabasal acantholysis here. Really, going into the follicular epithelium, this is something that you often think about pemphigus vulgaris doing this. However, this was not ultimately pemphigus vulgaris, and this was really Hailey-Hailey, where you get this kind of almost like full thickness acantholysis in some of these areas. It just happened to sort of interestingly have just a lot of follicular involvement. They had the typical classic presentation of Hailey-Hailey in the folds and everything. So in this example, can come with a differential. And we got a comedone here. You might have had a portion of another comedone here. You got another one here. Another kind of comedone here. So we have multiple kind of comedonal structures in a small area. So some of the possibilities for this can, a cluster of acne comedones. It could be a nevus comedonicus. And somebody put down the correct initials, Fabre Raccuscio. So this was Fabre Raccuscio. All right, anyone? Any thoughts on this one? Is that more representative of what they're seeing on that TV screen or on the laptop?
The laptop would be the, depends on the screen.
Yep. Okay.
So I guess they have a screen.
Okay. Yeah, so this is a pretty well demarcated upper dermis proliferation of some kind of elongated wavy spindle cells. And we got some fracturing, so-called fracturing within it. And so, yeah, this is a neural neoplasm, and it is palisaded, encapsulated neuroma. PEN, good example. This one's just kind of for fun, if this is your idea of fun. Got this large, I don't know, this must be like a 6mm punch biopsy or something, and they had this kind of foreign material right in the middle of it. This was his last bite. It's me trying to be funny. So this is a tick bite. So somebody had a sort of a retained tick part, and then they really took almost an excision of it. I don't know why they took so much tissue. But anyway, this is a, for interest, just a tick mouth. All right. Let me go to another piece here. So this slide just kind of looks, is going to look kind of, muddy and dirty to you guys, just because there's a lot of, as you can see, a lot of pigment kind of throughout here. Lighten this up a little. So I'm going to kind of take you around the periphery of this lesion. All that pigment. A little higher power here. Anybody know what this type of pigment is? You think it's melanin? You think it's boron? You think it's hemosiderin? Yeah, hemosiderin, somebody said, and that's correct. A lot of it. And as we go around it, I think you might be able to appreciate, there's actually a little bit of like collagen trapping here at this periphery. You see that. A lot of hemosiderin, very cellular, and this kind of overall architecture, when you look at it, you could sort of start to buy that this is almost like a DF kind of trapping and nodular centrally with all this cellularity. So, and that's right, that is a hemosiderotic dermatofibroma. There's a few different names. Quality of, yeah. Yeah, this is more, and somebody put Bednar, but yeah, this is more well-defined, a lot of hemosiderin, and this is also referred to, other than hemosiderotic DF, this is also referred to as a sclerosing hemangioma subtype of dermatofibroma. So sometimes they can look a little scary when you first put these up, a lot of pigment, a lot of cellularity. All right. What are we going until 5 right now? Okay. What's that? Okay. All right, and we'll go on a higher power. You can sort of appreciate in this little area right here, kind of some interstitial cells right here. Going a little higher power. And those are actually interstitial histiocytes. And there is a little bit of fine mucin in those areas as well. Same thing here. You can kind of see that there's a little bit of an interstitial histiocytic infiltrate right here, going higher power. And and there's some mucin in there. So this is GA. And going to higher power, we can really take a look at it. Really, you can see some mucin in those areas. So this is GA. A little less, maybe less obvious, not so obvious a palisade as in the other ones, maybe more of a kind of an interstitial pattern. And then, looks like we've just got a few more minutes here. This is a big piece of tissue. It might be a little challenging on this system to show you, but let's get through it because this brings up a whole big differential. So we got this large tissue. I'm just going to tell you it's from someone's scalp, which you almost can kind of sense. And then in this area, you can kind of sense that there's a inflamed hair follicle, some suppurative inflammation. Follicle feels like it's kind of getting destroyed. It's kind of getting eaten up, and then we'll go to this other area, another hair follicle, a lot of inflammation and fibrosis really throughout here. Inflammation, fibrosis. There's a follicle. These follicles are kind of getting eaten up. This one almost feels like it's going to be a free hair shaft soon. Suppurative inflammation kind of through here. And then there's a free hair shaft right here in the dermis. So this happens to be acne keloidalis nuclei, and somebody just said that. That's great. And let me show you just another piece. Same patient, upside down. So really, inflamed hair follicles, mixed inflammation, destruction of hair follicles, and the intervening stroma is a mixture of sort of fibrotic and inflamed. So when you see this kind of picture, there are some other kind of things that can give you roughly this picture. Anybody know what some of those other entities that kind of are on the differential are? take forever for you guys to type it, sorry. So dissecting cellulitis, yeah, folliculitis decalvans can definitely give you that kind of pustular, follicular with scarring and inflammation picture. Dissecting cellulitis of the scalp, you can get it with the hidradenitis suppurativa, can give you that picture. Pilonidal cyst can give you a similar picture. So whenever I see this kind of inflammatory pattern, you know, it's actually pretty characteristic. You just go straight to the requisition and say, okay, where's this from? You know, if it's a gluteal cleft, it's a pilonidal cyst. Occipital scalp, it's going to be acne keloidalis. Anyway, just a good differential exercise on that one. And then that's other slides here. Maybe let me see, or maybe I put them over here. I'm going to show you one other example, and I think we can wrap up. I've been out to Chicago a few times, and I've met several of you. Some of you might have already seen this one, but I just thought this was an interesting case. It's almost the danger of too superficial a biopsy. So this was a shave that I received from a doc in Florida, and you see that it's basically excoriated here. So the epidermis is eroded. It's just an excoriation, you know, not much to it, except the only thing I noticed was, what are these little blue cells down here? And they're just too prominent to blow off as just a lymphocyte. You know, there's lymphocytes over here, but these blue cells are larger, and you know they're there. It's let me brighten that up. Higher power, you see just a few in the just hanging on to the edge of the specimen. There's a few right there. So I put in the report that there's some atypical basaloid cells at the base, but I don't know what it is just yet. But you got to get a bigger piece, re-excise it, or do whatever, and just to get more deeper tissue. And then they did that, and then this was the shave from before, and then look, we have all this in the deep dermis and really going into the subcutaneous tissue. So they took a tiny shave and got lucky that we had those few cells that we saw in the previous tissue, a few cells, just enough for me to tell them get some more. And then if you go into here, you'll see these really kind of basaloid, strikingly atypical kind of smudged nuclei, and so this is a Merkel cell carcinoma. So somebody said, did somebody tell me I should come out to Chicago again? Is that what that meant? I would love to. All right. I should be there for St. Patrick's Day, but I think that would just result in a headache. So anyway,
Yeah, big thanks, man.
all right, awesome. So we'll plan on doing this again. I think Rob will coordinate to do it again. We just this is our first. We had 18 attendees, so that was awesome. We just wanted to make sure that hey, this was actually valuable, and even though the technology is cool and all that, it's only good if like on your end you guys can really see it well and really get something out of it. So. If there are any issues or anything that just seemed like it could be done a little bit differently, we would love your feedback because we're trying to make this session better in the future. So thanks to everybody for joining me. And again, any questions or whatever, just let us know. Somebody said to come to Chicago to do this in person. Well, you know what? I love Chicago, so that's about all I need to know. Maybe I'll combine it with a weekend, and I'll plan on coming out then.